Hey everyone, this is the Nips and Sips podcast. Featuring me, I'm Dr. Jeremy Boyd, and over there is Dr. Brandon Cruz. Today we're going to be talking about one of my favorite things is cuboid syndrome, mostly because it has my last name kind of built into it. But before we get too much talking into that, let's pass out to Brandon. How's it going?
Going well over here. Yeah, we petitioned to change the Cuboid Boid to Boyd,
Oh,
which
yeah.
is the last name. I know that's one of your favorite techniques, which we're going to talk
Mm-hmm.
about a lot later on today. But first, what we're drinking. It was my birthday this past weekend, so
Happy
I got
birthday.
a lot of a lot of new bourbons and scotches and whiskeys and stuff. I did not crack one open, though I should have, but I have this awesome new Crunk cup, and there's a story behind it. One of my very good friends, my brother from another mother, I met in PT school, Eugene, a.k.a. Yevgeny, or G-Money, as I call him, got me this awesome Crunk cup, which I found out is not really a Crunk cup. They were out, so he got me a candle holder to put the lovely bottle of the Balvine in, 12 years aged. I was thinking about cracking it open today, but I decided not to. Save that nice bottle for another day. But Jer, what are you drinking on today? What are you sipping on?
Can you show the whole thing, just the
Oh
stem
yeah,
and
yeah.
everything? Look at look at
So
this
I was
thing.
like, oh, that's a bomb ass cup. So for those of you who are watching, and if you're only listening, you should watch it. The bottom half is like
This
painted like a, I don't know, like a rose gold or something. So
That's
I made
beautiful.
cake out of it today, and then give it to my
Slick.
lady so she could put some candles in it, or I just make it my Crunk cup,
Awesome.
my
I think
unofficial
you should keep it your cup. Because
official.
looking at just the top, it looks like it is a badass cup. But as soon as you lift it up, it's yeah, dude. Spin that
Like a
around.
meme going, yeah.
Yeah, you need the chain and everything, dude. Today, I'm drinking. We'll be drinking Maduro Brown Ale from Cigar City Brewing, which is in Florida, which we had a lot of at AOM. I feel like I had a lot of these beers. Not this one in particular. I got this from that little winter pack that you gave me, and
Nice.
let me crack that bad boy open. And it's a brown ale, so it's got some semi-sweet kind of chocolate and toffee and coffee kind of sort of thing into it. Hopefully you guys can hear that sweet pour. And I'll do a quick. Oh, my glass is from Amsterdam, which is cool. So Amsterdam has a lot of cool breweries. If anyone's ever interested, this one was I can't even say it. So De Praal or something like that. But really cool place. Amsterdam is one of my favorite cities. I would go there in a heartbeat.
Well, yeah, you went the beginning of this year before shit hit the fan.
Yeah. So kind of blessed that we got to go. Had a blast, and yeah, it's gonna be a last trip for a long time. But um, on the Jeremy Boyd scale, pretty classic-y brown ale coffee esque type of beer. Pretty good. I'm gonna give it a 7 flat, just 7.
All right, all right.
Nothing like too crazy.
Nothing
Just
fancy.
down the line. But yeah, let's get talking about, I guess, cuboid syndrome. I guess I'll talk about why, besides it being that, the name similarities, why I like it so much was this was my very, very first eval, my first to fill. So I was always kind of
It was meant
partial
to
to
be.
it as a, huh?
It was meant to be.
It was meant to be. It was just, we're locked in, and I remember it was the first week, and initially my CI might have been the first, maybe very early into the second week. My CI didn't have intentions of us. There's another student that they had as well, who just started like a week or so before me, and didn't have intentions of starting us off on evals or me on an eval that soon. He wanted me to get a little bit more of a feel of the land there, but he got a couple evals scheduled, and he was a very similar kind of thing, some direct access and stuff like that. And he's just like, we got an eval, who wants to do it? And I was like, yeah, I'll do it. And he's just like, what you would know about cuboid syndrome? And then I just laughed. I was like, I know the cuboid's a bone. And he started laughing. He's like, all right, good enough. And so, yeah, it definitely wasn't my sexiest eval. I'll say that. It wasn't like, oh, I nailed it because I was meant to be on the cuboid syndrome. But I remember it vividly. It was a middle-aged woman. Can't really remember her name. I want to say Jess. We're going back 8-9 years now. But she was a bus driver. And I think it was a script that said cuboid syndrome. So that I've still have never seen to this day.
Yeah.
Never seen that to this day. I do remember seeing it on the script. That's usually, and we'll talk about that. It's usually something we as PTs are diagnosing. But I looked at the cuboid. I researched it all night. Knew what to assess and everything like that. But I did not come into the game day one doing cuboid whips on people. That was something that had to be mentored via my CI. But Brandon, what about you? What's your experience with cuboid syndrome? Or let's get the conversation going. Besides me being nostalgic here.
So I don't have that nostalgia like you have of remembering my first time, if you will. Yeah, it kind of came up probably through one of my evals. I remember really kind of learning and diving into it, I guess, during residency. This is, and for you folks out there, often misdiagnosed, perhaps quote unquote underdiagnosed, mismanaged, definitely. It's either, not talked about enough, not enough people are aware of it. It may be misdiagnosed as, I guess, kind of heel pain or plantar fasciitis, or maybe lumped in there with, the sprained ankles, and because it usually happens during a sprained ankle. So a lot of times people will just kind of keep doing the same thing and be like, oh, I get better over time. I get better over time. But if you, take a step back and really evaluate the whole foot and not just the ankle joint, but all the midfoot joints, and listen to the mechanisms of injuries, as well as when people are complaining of pain. And a hallmark sign is not only tenderness to palpation, on that plantar aspect of the foot, obviously closer to the fifth metatarsal, but they have pain during push off. And that's, something, or one of the things that I look for, at least in my questioning or during the subjective portion when I'm listening to a patient talk, and to see if they kind of say that. And we've talked about this, Jeremy, before. You listen to a patient and they'll tell you what's wrong with them. Listen long enough to tell you how to treat them. So I definitely think that goes under that philosophy there.
Yeah.
So I have a little story later on. I'll get back to residency and cuboid syndromes and diagnosis and what's happening mechanically or neurophysiologically and things like that. It's just something that's always stuck out to me, and I share it with everyone. So I'll get into that later. But how often are you seeing this, Jer? What's the patient population you're typically seeing this in? And I guess what are you doing? Foreshadowing to our cuboid whip.
Oh yeah. Yeah, I would say I couldn't agree with you more. It's extremely misdiagnosed, or just missed altogether. I don't know about you, Brandon, but I didn't receive. I know, again, didn't know cuboid syndrome was a syndrome until that day, that first eval. It was something I was like, oh, I had to look you up. I don't think it's mentioned too often in standard musculoskeletal classes at PT school, or even athletic training school or anything like that. But yes, for how often I see it, I would say I would probably even push towards, if it's a true syndrome or at least a component of the cuboid impacting like a classic lateral ankle sprain.
Yeah.
I'm gonna say at least maybe a third of those those people are coming in just for an ankle sprain have some sort of cuboid involvement, maybe more at times. And yeah, it's a lot of what they'll report is a little bit further. They'll just point to that area, but sometimes they'll, say it's like, or even with fifth met stuff, we start to like look at the fifth met. People think that, they got stress fractures, runners especially. And then you as you were saying, I hear a lot too is with that push off, or, very long distance running. And we start to like, maybe it's, fifth metatarsal fracture, but if you're really good with your palpation skills and you're, off the base there and go onto the cuboid, you can really dive in. And I think, palpation is probably one of the biggest things when it comes to kind of ruling in, ruling out that cuboid, especially on the dorsal and the plantar aspect. It's one thing if it's this tender on the side or those sort of things, but real tender, if you kind of get a good like C grip kind of hold on both the plantar and dorsal aspect, it's pretty tender there. And they say, hey, that's the pain that I have. That's usually some hallmark signs that I see this is the issue. And then from there, I'm looking at the other side, and I feel that it's not moving right, it's stiff. I'm trying to put in PA AP glides, so I see that that's something, a bit of an issue. That's when I'll start to go into doing some manual techniques. But I'll show. We'll roll right into that. Overall, before kind of miss a question or two, who gets this? I mean, probably most of my population's a little bit younger. I've seen a lot with cheerleaders, gymnasts, and volleyball players. That I've had a handful of adults too. And when you figure this out and you start actually treating it, it's money. I say there's unless you get people very acutely, there's very few home run hits. Obviously, there's a process in rehab, but if you tease in that the cuboid is the true pain generator, it's the problem, and you mobilize and loosen this bad boy up, it's a 9-day difference for a lot of these individuals. But yeah, what I do, obviously, to kind of loosen up, sometimes really depending on the patient's irritability, you gotta always respect that, their comfort level and those sort of things. I try and mobilize it. Sometimes you can just do APPA glides, which I found some success, but I think the most effective thing is kind of getting there with that cuboid whip, which I'll show right now, and then I'll tell a funny story of like how I did not respect the patients. I guess and not beliefs per se, but did a cuboid whip without letting the client know. It was a home run hit for her, but she did not really appreciate that. She was facing the other way. I was like, I'll just do this real quick, and it shocked the shit out of her. And that was not my finest moment. But after that, she came in one more session. She said she feels great and was pain free. But make sure you let people know that you're about to do this maneuver. So I'm going to show. I'll do kind of something funny. I'm going to show you. So this is my old company, BSR, great place to learn. I'm going to show you what growth really looks like. Just overall, just confidence. And, well, firstly, screw this. I'm going to share, because this may take a second or two. They posted up a lot more than I thought, but Brandon, did you ever see my first manual Monday? If you guys don't follow Trifecta and stuff like that, I've been doing manual Mondays or technique Tuesdays since I started the company.
I'm not recalling.
Oh, wait.
2 years back, but
yeah. So something I've always been doing, but the first it ever started was when I was at BSR Physical Therapy. I don't know why they trust.
We're on Marky Kev here, so we're not anywhere near.
Yeah, we're going close. They kind of ramped up, which I'm happy about. They ramped up their see, this is me coming back right here. So this is growth at its finest. So this is super awkward. It sounds like a jackass video, but so look how clunky I am. We can look at that one more time.
Look at that dress shirt they made you wear.
Dress shirt, yep. Like stiff as can be, way far out from the client, and just awkward at it. Effective, but not sexy at all.
Looks like a
Um,
golf swing.
yeah, that's about right.
I can't talk. Mine's not much better.
Yeah, hold on. And then let me share one more. And then you guys can see this. So I'm grabbing that, kind of getting that C grip on that cuboid right there. I'm applying a P to A kind of glide. I'm a little crisper, a little mini thrust, and then thrust. So that right there is growth at its finest when it comes to this, and that's a little bit more of a, and then so just different varieties. I'm doing an inversion and I'm doing it in neutral in this case, but this technique, I usually don't do it this many times. We're doing it just for video purposes. But Brandon, um, I know you have a standing variety, but yeah, that's something that if I figure that that is the problem, doing that technique usually is money. Again, just let the client know they're facing away from you, that you're gonna kind of give them a little thrust there, and they usually appreciate that a little bit more. But what about you? And then obviously exercises, but we can probably talk about that later. But what about you, Brandon?
I'm just going to circle back around just for the audience on other, I guess, athletes or persons that are susceptible to something like this. Now, obviously, anytime you have a patient who's had a inversion ankle sprain, especially, or trauma to the foot, I mean, I'm assessing it. I'm assessing the whole foot, but definitely throw it in there on those inversion ankle sprains.
Mm-hmm.
Ballet dancers or dancers in general are a huge population. I think almost 15 or 20% of dancers get it. So that shows you that. And then soccer players, football players tend to get it. I see it a lot in those either cross country or we talked about this last time. Those tough motor runs, like people who do like those obstacle course runs because they're
Mm-hmm.
carrying like rucksacks and weight and uneven terrain, and they'll get it. That was actually we had a patient who did one of those Spartan races. This is when I had my first intern, and it was a great case for her because I think we cleared up a lot of the foot stuff within a couple sessions, and then he still had some lingering stuff. And I said, check the cuboid. She did some manips and mobs, and literally another 2 sessions later, he was good to go. So that was good. I'm going to show a couple other tests. I don't utilize these tests, but these tests are in an article of a case study. If you want some special tests to help you diagnose or rule in this pathology, I don't think we need them. But again, if you want to be thorough, if you're a young clinician and really want to go down that road of checking all your boxes before you're jumping to conclusions, definitely all for it. Jeremy and I, seasoned clinicians, highly trained therapists, and sometimes we cut some corners and have, type 1 reasoning where we can recognize patterns and things like that. So let's pull that article up. So if you guys are watching, this article is by Jennings in 05. Talks about palpation. Here's that C grip that Jeremy was talking about, grabbing dorsally and plantarly to see if they're tender. This next one is a mid-tarsal adduction test. So basically pretending like you're breaking a piece of bread on the lateral aspect of the foot. And then this last one here is more of a supination / inversion type test that is supposed to stress that area up here to the right. So those are some tests you could throw in and see, how valid they are, if they replicate the patient's symptoms, which is what they're supposed to do. So just some food for thought for you guys there in terms of that. Jer, I believe you asked me to share that video, correct?
Yeah, so I like this. I've done it a handful of times with the standing one. Good for like competitions and stuff like that if you need to get it done. But I think you have
That's
it.
a great thing. I mean, for you therapists who start up your own businesses and gyms, and maybe you don't have the tables, or you're maybe doing a competition, a CrossFit competition or weightlifting competition, and somebody's complaining about foot pain, or maybe you're doing some on-field stuff, and you really don't have the table. They could just bend over and hold on to something. This is what this technique will look like.
And guys, for future, we will be putting up the links to the articles, and then we get some feedback. Oh yeah, I like the title here, Brandon. I like how you.
Yeah, I renamed it. Yes.
My man.
Hold on. Let me, it's not big enough. Hold on here.
What we can do instead of Cuboid, call it Cruiseboid. Now we get both of our names in it.
We could make a petition for
Or
that.
Cuboid.
Everyone see this? Yeah. So this is in the video membership that we made, Jer. For the audience out there, I mean, we have step-by-step techniques. We'll get into that later, but you can see that the patient here is using the table for balance. My thumbs are placed over the cuboid, palpating, applying an anterior force or dorsal force, and then I'm going to apply a thrust here. Apply a high velocity, low amplitude thrust in a small whip-like fashion while sustaining localized pressure on the cube.
Look at that power stance.
I'll play that last little clip again, just so people who are watching can see that thrust, that smooth whip.
Smooth whip with the power stance.
That is that. I mean,
that's right there. That's money.
You know, I would say, did you ask anything else? You're talking about exercise, right, Jared?
Yeah.
In terms of exercise specific for the cuboid, I don't really say I do. I mean, I've literally had people, you do it and they're like pain-free. It's like, why bother? Now, if we're talking about prevention and what led to their injury, and we're looking maybe at hip strength, pelvic strength, the way they run, you know, put intrinsic strength, posterior tib, you know, is their arch collapsing and things like that? Yeah, obviously, you know, we're going to go and, you know, make our exercises and treatment based upon their impairments. But in terms of just if this was a cotton dry cuboid syndrome, or even a lateral ankle sprain with underlying cuboid syndrome, like you said earlier, I'm treating that. I'm getting that pain, you know, to zero, and it usually happens pretty quick. You know,
yeah.
I think we both said within, you know, probably 1 to 4 sessions max, and this stuff clears up.
Yeah, I always try to, and especially in a way to kind of foster, you know, independence, because that's what we do. And I always feel like you should always facilitate your manual therapy with like some self techniques. I've tried showing people how to like do a self PA glide to their own cuboid. It seems like it would work. I mean, I've done it on myself where I'm like, oh, I can feel, you know, the actual translation and stuff. Overall compliance and how well they do it. I like to think that it's a simple thing. You just like grab pretty much everything else, hold it tight, and just move this part. Overall compliance, though, is probably not the greatest in the overall performance. So I've pretty much bagged that. I even done it once where it's like it did real well, and then I don't know, maybe during my assessment I was like playing around, like applying a PA glide. I've even tried to like tape in that, like do a PA glide, tape around to kind of sustain it. That seemed like it helped, but again, not something I typically would do often. Usually, again, this is a home run hit and they feel great afterwards. But I've kind of toyed around with those sort of things. But then, you know, everything else that you said, like looking proximally, checking proprioceptors, all this sort of stuff, checking like the arch. Yeah, I've gone around and played with it a lot. I know. And do you do any like dry, like back when you could do dry needling? Is there any dry needling of that area? I know I haven't.
Not really.
Really?
I mean, I try not to dry needle, or when I could dry needle foot. It's just not comfortable. So I would.
Yeah.
It was always a technique of last resort if I could help it.
Yeah.
You know, I would try and do as much manually and you know, stretching, mobilizations, nerve glides, etc. Treating the whole foot complex. But you know, if it's something really chronic, if I could try and get in there around the joint lines and do some stim and try and, loosen up that area, quote unquote, or get it to be less bound down or less kind of gummied down. Do it and kind of hope that was able to loosen it up so I can make my manual techniques better. But for this type of syndrome or diagnosis, I never really dry needled, felt the need to dry needle. You don't have to manipulate either. You can mobilize it. I think you touched upon that. I want to share this article here real quick just so you guys can see. This is another case study by a gentleman, I believe Lewis, in 2014. Cuboid syndrome and why manual therapy helped. I think he goes into a great case study here and goes into the mechanisms at play, all the way from eval and differential diagnosis to what's at play. Is this a biomechanical intervention or based intervention? Is it have neurophysiological interventions? Is it placebo? Probably all three of them. What happens with sensitization? What is our thrust or mobilization doing at the pain processes levels or the nervous system level? So I like that. I think it gives you a nice, well-rounded viewpoint, especially integrating it into a case study. In our profession, we've talked about this a lot of times, Jeremy, with the pendulum that swings from manual therapy to pain science to patient education to hands off and just doing squats fix everything. These movement therapists that just feel they just have to have their patients, move, and that's going to get everyone better. I think it's important to understand that there's multiple mechanisms at play. I can't drive that point home enough. And the story I wanted to share, I think this is a good segue, was in residency. We had a teacher, a professor named Heidi. She was actually my, mentor or supervisor through the program and challenged me like no other. And I thank her for that. But I remember she felt like everything we did was neurophysiological, like just rammed it down our throats. And, at that time it's like, okay, I guess all this biomechanical stuff that you learn in kinesiology and orthokinematics and rolls, glides, spins, and slides and isn't really what it was. So, spending almost a year with her, and we had one class where she covered the foot and ankle, and cuboid syndrome was brought up, and the technique of cuboid to treat cuboid syndrome, cuboid manip, was brought up, and she explained the mechanism or the diagnosis of inversion ankle sprain causes the peroneals to contract, violently or strongly, causing the cuboid to shift out of place. And I remember questioning her, and then that the technique was one that puts the cuboid back in place. So of course my smart aleck self questioned her and questioned that and was like, well, if biomechanical occurrences don't take place, why did you just explain everything biomechanically when there is probably more of a neurophysiological effect to this with sensitization? Needless to say, she got a little flustered, really didn't answer the question, and just said, that's how they explain it, is what it is, and kind of moved on. But that was like my awe or my pullback of not going down that, or not continuing down that rabbit hole of it's only neurophysiological, it's only placebo, and all that other crap. That, there's some stuff here that maybe, MRIs or imaging or these tests that people do in studies can't pick up, or these markers can't pick up, but maybe there is a subluxation. Maybe Mulligan was onto something back then. Can we prove these positional faults? Do we need to say and use verbiage of positional faults and subluxations and dislocations and things like that? Probably not, but I think we as clinicians need to understand that, it's probably a little bit of everything going on. And that maybe subtle shift, even if it's a tenth of a millimeter, is enough to have that, the person's body become sensitized, sensitive, cause joint, decreased mobility, and have increased hypertonicity of the surrounding muscles to try and guard things. So I definitely think we need to just be more open-minded with stuff like that. And I think that's pretty much all I have to say about this topic, Jer. You got any final thoughts wrapping up here?
Yeah, I mean, based off of what you're saying, as I always think it's, I felt I was pretty deep in that rabbit hole. Like it took me a while to kind of squeak myself out of that one. Um, you know, it doesn't hurt to treat biomechanically. I think there can be some issues educating people with biomechanics, getting into
That's great.
name grid.
You say that again for the audience. That
I
summarizes it perfectly.
Yeah, I think it's no problems. I think it's great that you can treat biomechanically, but to educate your clients biomechanically could be an issue. So why not, with your manual therapy or anything like that, get into nitty gritty. Man, they don't know what the hell you're doing. You can say your manual therapy is tickling their feet and it's going to fix them, and they're going to be okay, whatever. But what's the hurt in trying to maybe again put something back if that's the case? I know like true like lateral ankle sprains. My mentor, Tom Michaels, when I was going through my OCS, he explained as those like the ATFL, they get pulled and stretched. They kind of push the lateral malleoli or the distal fib in the anterior direction. So putting it in a more posterior or forming an AP glide on it can relieve symptoms. And sure as shit, every time I do that, it helps. So is there a neurophysiological effect, or are we really putting things back together? But I don't tell the client that. I just do it. They feel better. And I move on. So it's the best of both worlds. And I'm getting light into that more in my fellowship training. Yeah, you can do non-specific things, kind of do those neurophysiological things. But in my experience, the more specific I am, especially with my manual therapy, the more efficient or shorter length of stay I have people, as in they get better faster. They're going to get better. You can try and blow up things with any techniques you want or whatever philosophy you believe, they'll get better. But I know people are getting better quicker now. So yeah, that's just my I guess 2 cents in on that biomechanics versus neurophysiological effects. But no, that's oh god, yeah. That's about all I have to say on that. That was a good conversation. Thanks for letting me talk about that, Brandon. My favorite thing. But yeah, hopefully you guys enjoyed. We'll put up those articles that Brandon so nicely outlined for us on the comments section of the post on social media and on SoundCloud. On top of that, if you have any questions about like the techniques or anything that you saw or listened to, feel free to reach out to us. We're at the Nips and Sips, I'm at the Decent Doctor and at Trifecta Therapeutics, and Brandon's at Think Like a Fellow and at Pursue PT Now. If that manual techniques really piqued your interest, or just never heard Pursue PT, I'm not Pursue PT, sorry. You should. Everybody should know about Pursue PT, the greatest PT in the north side of Jersey. East Coast, baby.
Like separate the north side. You got the south side.
North side. Yeah. So like
the south
north.
side. We'll take it. That's fair.
We'll take it. But if any of that like piqued your interest, Brandon's done an awesome job in creating a awesome library and mentorship and membership for manual therapy and overall orthopedics and sports. Brandon, I don't know if you want to throw into anything about that. I know we had a couple people talk about it and interested in it.
Yes, I would love to share with the audience. Always just trying to make this profession better and pay it forward. As you and I have been fortunate enough to kind of go on our path and go down residency fellowships and owning a business. So we have two platforms. One is only videos. It's 100 videos right now, manual therapy techniques covering the spine and the extremities. With more to come, probably dry needling, neurodynamics, PNF, things like that, which you won't be charged extra once you buy it. So, the one-time fee, and that's it. You have access. You can download it on your phone, make an app of it on your phone. There's directions there once you make the purchase. And then for those who want mentoring, whether it's mainly obviously like Jeremy said, manual sports orthopedics, but we also have a business section on there, being that myself, Jeremy, and our third amigo, Kyle, are all business owners. We figured we'd throw that section in there as well, for people trying to, go out on their own. There's that aspect. But in terms of the manual therapy mentorship, that's basically a residency and fellowship. It's the models that we've gone through, distance-based, able to upload articles. There's over 600 articles there. We have discussion boards and bi-monthly calls to talk about, patient cases and things like that. So for those of you who maybe didn't get what you wanted out of your DPT or residency program, or just hungry to learn, or have been practicing and just feel stagnant, you have 3, sharp minds where you get to pick our brains and have access to basically all the materials that we have had. We're just kind of funneling that up between all the articles we've read, the techniques we've done, ebooks that we've posted, books that we've read that we found beneficial in terms of leadership or business. And it's just a central hub of that information.
Yeah. I think it's awesome. So thanks for leading that. Yeah. If you're like, I don't know, what cuboid syndrome, and you just decide to watch it, this is that sort of stuff that you can really benefit from. We talk about these sort of things in that mentorship. So yeah, hopefully we can, help some of you guys out. And overall, thank you for listening in, and cheers, everyone.
Cheers, guys.